In this Module 3 video, we'll be talking about measuring the quality of care. Our objectives are to describe why it's important for healthcare managers to understand quality measurement. We'll discuss how surveillance systems can be used in hospitals to support measuring quality. And then we'll talk about process and outcome measures and a bit about the pros and cons of using each one when we evaluate healthcare quality. So to start, why is this important? So just as a reminder, monitoring programs and care quality are part of the control function within healthcare management. And these activities really link planning to operations. And largely they revolve around quality and financial management. And that's really the focus of this module. We'll be talking about quality in this video and then more about cost in the next video. So it's really important as a manager to understand the data, where they're coming from, and how we think about quality in order to make informed decisions about operations and strategic activities. So how does epidemiology relate to quality management? Well, for one thing, we can use descriptive epidemiology to measure quality, for example, across our hospital or institution system of care. So some examples of the way this might look are to look at the person, place, and time characteristics associated with higher levels of quality. So for example, at the person level, we might look at patient characteristics, provider characteristic, or even groups of providers or units, and looking at whether things like provider training or credentials were associated with better quality of care, whether demographics of patients or of providers were associated with higher quality. So that might be things like patient age, sex, race, ethnicity, all those person variables we talked about before. And on the provider side, we might look at those same demographics, but we also might consider things like experience or the number of previous treatments that the provider had done of a certain kind or the number of procedures. For units, we might look at things like management structure, patient loads, and how that's distributed across providers. For place, we could think about departments being the place within a healthcare system or hospital. So this might be things like looking at quality measures for inpatient versus emergency departments, looking at pediatric versus adult care, and then looking at care on the floors versus those in diagnostic settings or rehabs, lab, that kind of thing. Finally, we might look at the time characteristics associated with quality. So that could be different shifts, night shift versus day shift, parts of the week. So is weekday quality different than that provided on weekends? Are there variations within a month? So earlier in the month versus later? And then are there seasonal or annual differences in quality? So just as we talked about with general epidemiology approaches, these descriptive data might suggest some issues that we could explore with more analytic approaches. So this could be areas that we might want to intervene to try to improve quality, or it could be that we might see some areas where we might be able to increase efficiency while maintaining quality based on these descriptive epidemiologic data. So then when we're ready to start collecting data, there are a number of things that we want to think about. First is the system. So hospital surveillance systems are similar in some ways to more general surveillance systems that we've talked about already, although of course they have some unique features and things to think about. So the concepts that are the same are that surveillance has the same definition in a hospital as it does in a broader setting. So we still want it to be systematic. We want rigorous, high quality, valid, reliable data to be collected, and we want it to be done on an ongoing basis. And just as we talked about before with some of the national health surveillance systems that are done by telephone or in person, the focus of our surveillance system would probably be on the same kinds of things, or we would consider the same kinds of factors when deciding whether or not to do surveillance on a particular condition. So we probably want to focus on those that are high cost, common, serious conditions for which a treatment or intervention is available. So we want to be able to prevent health problems, and we want to make sure that they're having a substantial impact on our delivery system before we set up a surveillance system around them. Because again, surveillance, because it's ongoing, because we need systematic, rigorous data, they are intensive in terms of resources. So cost intensive, time intensive. So we want to make sure that they are giving us usable data and that it's actionable. So some typical focus areas for surveillance systems within hospitals, you may have one overarching surveillance system, or you may develop independent surveillance systems to address these different kinds of content areas. So the first one is infection control. And I think at this point, most facilities have some sort of tracking system for nosocomial or hospital-acquired infections in particular. But you could also look at a chronic condition surveillance system. You could set up a surveillance system around specific procedures, or you could have one that's aimed at identifying adverse events specifically, and that might cut across different kinds of treatment areas and conditions, just looking for adverse events. So once you've decided what you want to focus on, you also want to consider how frequently you want to collect the data. So just because they are ongoing, that doesn't necessarily mean always happening. It doesn't mean it's 24 hours a day, and it doesn't mean it's happening everywhere. So you could have a hospital-wide surveillance system that really is encompassing everyone and all activities, but you may instead decide you want to focus just on the OR, for example, or on some particular unit or set of units. You could also do a periodic surveillance system. You just want to make sure that that period is determined up front. So maybe you want to do a surveillance system where you collect data once a month or once a week, once a quarter, some specific defined period over which you can expect the surveillance system to regularly occur. You could also do a targeted approach. So again, you might focus on a specific area. There might be something that came up in your descriptive epi assessment of quality, and so you want to just focus on those areas that you saw large differences or particularly low quality and do targeted surveillance in those areas. And there's an example in case study 5.1 in the textbook if you want to look at a little bit more about suggested hypothetical intervention to improve MRSA surveillance in a hospital. There's also a nice article that came out in 2015 that describes a completely automated system designed to detect those nosocomial or healthcare associated infections within a hospital. So this article describes the system that they set up and compares this completely automated approach to the more traditional approach in which infection control practitioners were identifying these healthcare associated infections. And so this figure here just gives a little bit of a flow chart of how this works. So their labs, along with their electronic health records, fed information into a database. And they had some algorithms and natural language processing systems built in so that it kind of filtered, went through, evaluated the data, detected likely events of healthcare-associated infections, ran through some additional algorithms, and then fed that back to the clients, which in this case were the infection control practitioners, other providers within the hospital setting. So again, the article is linked here if you are interested in learning more about that. But just one example of thinking of new or kind of innovative ways of doing surveillance within a healthcare system that would be a little bit less resource intensive in terms of time for providers to manage this. So we talked about data first and setting up the system, but you also want to think about what measures you really need. What data do you want to collect with these systems? So as a reminder, before we jump into this too much further, rates in general are better than counts. So rates are the number of events per population at risk per unit time. So keeping in mind that we only want to put people who have a non-zero chance of having the event that we're looking at in the denominator. And this is particularly important in a situation in which a healthcare organization is growing rapidly, because if you were just looking at the number of events, but your denominator is expanding rapidly, if you have more and more patients that you're serving, more and more enrollees becoming involved with care, then that event, the number of events is going to increase even if your rate is actually decreasing over time. And on the same point, thinking about denominators, this exhibit 5.2 from the textbook highlights the idea that you would have different people in your denominator depending on what kind of rate you're looking at. So this table is showing different complication rates. And so aspiration pneumonia is the first row. And if you were calculating an aspiration pneumonia complication rate, you would only want to include people who had had surgery in your denominator. So people who have an invasive cardiac procedure or endoscopy or medical patients wouldn't be at risk for aspiration pneumonia as a complication of their care. However, if you were looking at wound infection as a complication rate that you were interested in, you would want to include all of these different patients, people who've had surgery, invasive procedures, cardiac procedures and endoscopy, and medical patients in your complication rate, because there are lots of different kinds of wounds that could become infected, and any of those patients could be at risk for wound infection. So again, just when you are thinking about calculating rates, which typically are used to report quality measures, you want to think about not just the measure overall, but how you actually calculate that. Who's in your denominator, who is at risk. Another aspect of calculating rates that you can think about is how you want to express those rates. So again, they're always per person per unit time. And so typically you would think about whole people, patients, and so you might focus only on enrolled members, so it might only be people who are enrolled in your healthcare system, organization, insurance plan who are at risk. But in some cases, it's possible that you would want to include a broader range of community members. For example, when you're looking at things like access, potentially you'd want to look at everyone in a particular geographic area rather than just enrollees. But there are other ways that you could express rates. One is to use time units, so you could use patient days, so the number of days a person is hospitalized. So for example, for healthcare associated infections, that risk might be better expressed instead of per person, per patient days, because a person could have more than one type of infection while they're hospitalized. And so it might be more useful to express it as a function of patient days. Or even if you're looking at surgery-specific events or complications, you could do patient hours in the operating room. So if a person is open longer, being operated on longer, does their risk for a negative outcome increase? And if so, it might make sense to express your rates in the context of patient hours at risk. A final way that you might consider expressing these rates is per healthcare episode. So it might actually make sense in some cases to look at the number of events per inpatient admission. So maybe if you want to just look at whether somebody was ever screened for cancer, for example, that's not something you would expect to happen multiple times. It would just need to happen once during an episode. And so expressing that per patient admissions or per outpatient visits would potentially be the most useful way to do that. Again, if we're looking at something that relates to a surgical procedure, we could express the rate per number of procedures rather than per patients. Okay, so that's kind of the measurement technicalities that you want to think about. But measurement content, what do you actually want to measure? The two major categories we think about are process measures and outcome measures in healthcare settings. So process measures are all of those aspects of care delivery, basically what is done to the patient. That would be classified as a process measure. So these tend to be a little bit easier to measure, and they're probably more directly under healthcare managers' control. So you could probably have more influence on changing processes than you could have on changing outcomes. And these are hypothesized to improve outcomes. So if you're thinking of kind of a flow, an event would happen, then these process measures contribute to outcome measures. So still important, and again, potentially easier to measure and more easy to modify. Outcome measures are those longer-term changes in health status that result from healthcare. So things like morbidity and mortality. In general, these require longer follow-up, and they're influenced by processes of care, but also lots of other external factors. So patient and community level factors could relate to outcome measures. And then within outcome measures, we could think about both intermediate and terminal outcomes. So intermediate would be things like complication rates, whereas a terminal outcome measure is typically just mortality. So if we want to think about some of those process measures. One example is clinical guidelines. So you're probably familiar with these. Typically, clinical guidelines are evidence-based recommendations for clinical practice that are designed to produce the best patient outcomes. So these are things that have been shown through studies, observational or randomized studies, to improve patient outcomes. These typically come out of professional societies. You could also look at the U.S. Preventive Services Task Force website or AHRQ's National Guideline Clearinghouse, both of which are linked here, to find guidelines if you were interested in particular conditions and needed some evidence-based recommendations. This is also a way that you could measure quality. So if you looked at the adherence to clinical guidelines, in other words, the percent of visits during which providers adhered to these guidelines, did testing as recommended, prescribed particular types of medications, those kinds of things, that could be a quality measure, adherence to clinical guidelines. So in order for that to work, you need to make sure that you are systematically collecting that relevant data. Otherwise, you might have to do chart review, which can be very time intensive, although using natural language processing is an option. So an example is looking at the percentage of visits during which a patient with a chronic foot wound or ulcer related to diabetes had the wound debrided. So there are clinical guidelines related to the frequency of wound debridement. And so you could look at, you could measure the quality of wound care in your setting by looking at the proportion of visits during which this guideline concordant care was provided. Again, that's a process measure. That's something that's happening to the patients and something that you as a manager could potentially intervene. If you see that debridement rates or percentages are low, you could roll out a program to educate providers, provide them the necessary tools, change the structure of wound clinics. Maybe nurses could do it instead of MDs, and that might get your numbers up. So there are a variety of interventions that could potentially result from looking at your this quality measure of adherence to clinical guidelines around wound debridement. And then, as we said, there's these two kinds of outcome measures, intermediate and terminal. So a complication rate is an example of an intermediate outcome measure. So if we're still thinking about chronic diabetes-related wounds, this figure here kind of shows one potential trajectory of how this would work. So someone is diagnosed with diabetes. At some point thereafter, they develop a chronic wound. They ultimately need surgical debridement of that wound. And then they develop an infection after that surgical debridement. So the complication of the surgical debridement is infection. So this might be something that you're looking at as a quality measure, complication after surgery. So infection after surgical debridement of a chronic diabetes-related wound. And that infection complication rate would be your intermediate outcome in this process. And then death would be the terminal outcome measure. So if you were interested in evaluating the quality of wound care and you wanted to look at outcome measures, looking at infection rates after surgical debridement would be one aspect to look at. And that would be subject to potentially fewer confounding factors between the process and the outcome. So again, the terminal outcome is survival or mortality. And the thought is that, like we show in this diagram, that it's impacted by complication rates, so that by having this infection, this complication after debridement, that increases the likelihood of death. But it's not always actually borne out in data. There are a number of studies that show that complication rates don't have a strong impact on mortality. So it's important to look at intermediate outcome measures because those might be more actionable. Again, you could probably implement better controls to prevent infection following surgical debridement, whereas it's more challenging to think about what interventions you might implement as a healthcare manager to prevent mortality, because there's so many other factors that relate to mortality risk that it's hard to intervene. Nonetheless, there are good reasons to still measure that. It may still be worth looking at mortality in your healthcare setting. It gives you a picture of both what your system's doing in terms of preventing mortality, but also what's happening in the broader community. So another way to think about this is if your goal is really to look at the risk of mortality as a result of treatment among your patients with diabetes and chronic wounds in your healthcare system. that you might think of it as a nice linear approach like we saw in the earlier slide, but this is closer to the reality. There are all these other factors that influence your patient's health status, one of which is a chronic wound and infection down there on the lower right. But this patient might also have cardiovascular disease and have a pretty sedentary lifestyle and have low income and other challenges around social support and getting to and from work and healthcare visits. And so all of those other factors also relate to their risk of mortality. So you are probably not going to be able to address all of them within a healthcare system. And so you may want to measure what you can control, but also measure these terminal outcomes and evaluate whether or not you're having an impact on those. So the last part of this module is to talk about tracking and comparing quality. So the Agency for Healthcare Research and Quality has a number of quality indicators in 4 different domains that they measure. Exhibit 5.4 lists all of them in your textbook. We'll just talk about the main categories here today. So the 4 domains are prevention, inpatient quality, patient safety, and pediatric quality. And a lot of these measures are around potentially preventable hospitalization. Within inpatient care, there are 3 different types of measures that make up that domain. And those are looking at things like the volume of procedures that are done, looking at in-hospital mortality, and then looking at utilization. And utilization can range from procedures to medications and other kinds of activities that happen while someone is in the hospital. So these are really useful for benchmarking, and they're also used for rating things like hospitals. So it's important to understand what's in these indicators and also to have a valid and reliable system of measurement for them. So as I said, most of those AHRQ quality indicators revolve around preventable hospitalizations. And that class of conditions is sometimes referred to as ambulatory care sensitive conditions. And so these are things that we feel like are preventable if people are receiving adequate management in an outpatient setting. So these have been associated with lower healthcare costs and improved population level health. And the kinds of things that fall under the classification of ambulatory care sensitive conditions are vaccine preventable diseases, acute conditions, and chronic conditions. So within each of these 3 categories, there are ambulatory care sensitive conditions. This measure of ACSCs was introduced as a measure of access to care in the 90s. So, if someone didn't have adequate access to outpatient care, then they would have more of these hospitalizations for conditions that were sensitive to outpatient care. But more recently, they've kind of evolved to be measures of quality. And so there's an ongoing debate about whether this is really appropriate. We want to measure preventable hospitalizations, but that's a really hard thing to do. It's difficult at an individual level to determine whether or not any one patient's hospitalization was preventable or not. And so that's why these ambulatory care sensitive conditions have moved in to fill that role, because it's a list of things that should be able to be managed in an outpatient setting and shouldn't need to progress to inpatient care. But again, there's debate about whether or not that's actually true, and that's the focus of our discussion for this module. So there's actually a reading that kind of summarizes this debate, and I'm asking you to think about it and give your feedback on it. So I won't spend more time on it here, but do read that article and then share your thoughts on whether you think ACSCs are an appropriate measure of quality. If you are looking for data, particularly benchmarking data on healthcare quality, the HEDIS dataset, the Healthcare Effectiveness Data and Information Set, is a great resource. This is out of the National Committee for Quality Assurance. And there are more than 80 performance measures in 5 different domains from more than 1,000 participating health plans. And we'll just go to one example here. So this is from their 2016 report. And so this quality measure is adult BMI assessment. So how frequently are weight and height measures being made among adults to be able to calculate BMI. And so to the right of you see a description here in the center, why it matters. And then to the right of the screen, there's a table that shows the rate of assessment, the percentage of adults who had their BMI evaluated by year and plan type. So you can see commercial HMOs and PPOs, Medicaid HMO, and then Medicare HMO and PPOs. And across the board, you see pretty substantial differences. So commercial PPOs had the lowest percentage, just 57% of adults had their BMI assessed, whereas the Medicare HMO had 93%. So pretty wide variation on this measure. But across pretty much all the plans, you do see that this has been increasing over time. So back in 2009, we see 15 to 40% of patients had their BMI assessed, whereas now we're closer to 80 and 90% other than those commercial PPOs. So this is just one example of the kind of measure that is available through the HEDIS data set. And HEDIS brings together multiple data sources. So the first two listed here come from NCQA. They kind of collect these data. One is the Healthcare Organization Questionnaire. So this asks health plans to complete a questionnaire about themselves. So that gives us the information about what kind of plan they are and some of the basic characteristics. And then there's an interactive data submission system through the NCQA website. And this is where hospitals, plans, providers submit their performance measures. So all of those things like we just saw, the percentage of adults that receive BMI assessments. And then they also link in AHRQ's CAP survey, the consumer assessment of healthcare providers and systems. So this is really satisfaction with care data. So all of this is put together in the HEDIS data set, which is available through NCQA. And then they create a number of reports, skip ahead here, including this annual State of Healthcare Quality Report. And that's the screen we just looked at a second ago for the BMI assessment came from their 2016 report, which is also linked here for the full report. And these HEDIS data are really useful for multiple reasons. One is you can compare health plans. As we just saw, there are these classifications of commercial and state and federal plans and types. They're also useful for establishing standards, so you can look at what patterns of care are, and it can be helpful to kind of look at distributions and think about where we should make cut points. And then they can also be useful to individual providers, facilities, plans to benchmark against others. This slide is just one example of how some facilities are starting to use quality measures in advertisements. So this is from the Kansas Surgery and Recovery Center, and they say our post-surgery complication rates for joint replacement are among the nation's best. And then they provide the statistics that show that their overall rating is higher than the national average, while their infection rate and DVT rates are lower, and that they also have shorter lengths of stays, a small proportion of unplanned transfers, and a low fall rate. Okay, finally, I just want to mention quickly quality-based systems. So pay-for-performance systems, while all healthcare systems really look at quality, pay-for-performance has a substantial focus on quality, and quality is actually linked to payment. So this could happen at the provider level, provider group level, or a combination of those. And so the goal is that, or the idea behind these is that it incentivizes superior performance. It is important to keep in mind that the incentive probably only exists for whatever quality measures you're actually including. So it's always important to think about what you're measuring, whether it captures an adequate scope of practice, whether it's capturing important health issues, since it's likely that people will focus on improving quality in the areas on which it matters in terms of reimbursement. So the approach in the pay-for-performance system is to use some robust healthcare data source like HEDIS to classify providers as good, fair, or poor on these high impact aspects of care. So, for example, providers who are classified as good, who do kind of better than average, might get a bonus of 1 or 2%, while the fair providers, those within kind of a standard deviation or whatever, limit of average, would just not have any bonus, but also not be penalized. And then those poor quality providers could actually lose money, so they would pay 1 or 2%. And accountable care organizations are one type of pay-for-performance entity. And so these are similar to HMOs in that they offer this continuum of care to a defined population and combine both delivery and financing of care. But they link this cost-saving quality improvements to provider payments using these performance measures. And the concept here is that coordinated care will happen as a result of the structure and the reimbursement. So in summary, delivering high quality healthcare is an aim of most managers. And in order to evaluate and improve care, you must have data that accurately captures care delivery. So it may be important to establish high quality data surveillance systems, use both descriptive and analytic epidemiology to understand the patterns of quality and care delivery and to intervene. And then you also want to make sure that you're measuring processes and outcomes that are important, that are actionable. Quality indicators are used to compare healthcare plans, providers, and to establish value. So again, you want to think about both process and outcome measures, which are most important to measure when you're thinking about quality indicators. And then again, ensuring that there are high quality and accurate data collected so that you can accurately reflect the quality of the care that you're providing.